The first question that I would like to ask everybody is, is it possible for us to get healthcare cost increases at least under the growth in CPI? And what are the initiatives you think that would best be likely to do that?
Well, I guess I'm up first since I'm to your left. It's going to be a challenge to keep it under CPI just because of demographics. We have an aging population who, as they age, demand more health care. That's inevitable. So I don't know if that's the exact benchmark to keep it under CPI, but we do need to control health care costs for all the reasons you mentioned before. It's a factor in business. It's a factor for government budgets. It's a factor for everybody's personal budget. The problems that I see as part of it is people don't feel responsible for their own costs as much as they used to. Those are the insured people. And even uninsured people that have Medicaid, when the rubber meets the road in your office, they want a lot for their copays and don't want to pay a lot more. And this division between what the actual cost is and what a patient actually pays is a problem. Until patients actually see the dollars that they're spending, and there is some effect for both the providers and the users of healthcare for doing unnecessary things, there's no reward to lower costs. I'm concerned in the future when we're going to pay doctors on shared savings, you're only going to be able to wring that sponge so dry. And those savings are going to go away. We're going to have to look for some way to make patients and people using the healthcare system responsible for the costs, because that's where the rubber meets the road. That's where the obesity problems are coming from and things like that. People aren't paying for the true costs of their behaviors. Even though they're not immediate, they show up down the road in your healthcare premiums.
Well, I mean, I'd say that not only the answer to that is yes, but we have to. I think when you think that, or just imagine that the country spends about $2.7 trillion a year in healthcare, and consumes about 25% of a family's median income currently, and it's projected to go up to 40% by the year 2040, it is a real issue. I mean, I think that Michelle's exactly right. I think you've got to do, one, is you have to do a different pay paradigm. I think the way we pay for health has to be done differently. And that is that it has to do two things. One is pay for value, and then incent people to have a different kind of behavior when they access the healthcare system. The second thing you need to do is you need to provide information. You have to have a more robust information structure so that people can make choices, so people can make informed choices about what it is, the kind of health care they need to access to remain well. And physicians and clinicians can actually make decisions based on evidence-based medicine. Not that that doesn't happen now, but it's one that we have to emphasize with a greater degree of clarity. We ought to have evidence-based medicine, not reimburse-based medicine. I think that's one of the things that we've got to do. The third thing is that the healthcare system has to find ways to integrate cost, or not integrate cost, but integrate itself so that it can take cost out of a system. It's been said that about 30% of the cost in American healthcare are excessive costs, things that are not necessarily that add value. And there's a great deal of opportunity there. The last point is one of the things that Michelle mentioned, and I think it can't be overemphasized. People have to take responsibility for their own health care. And they ought to pay a price to the degree that it's appropriate when it is they make choices that cost the system money. And what that means that we have to start teaching different lifestyle changes. We have to have nutrition. We have to have exercise. We have to have a whole host of things so that people can remain healthy and stay healthy. And if we don't do that, we're going to continue to use health care at a much greater clip than we as a nation will be able to afford.
I agree with the first two people. You know, if you ask me the single biggest challenge going forward, it's obesity in the state. 30% of our state is obese today. If you look at 2020, the rate could be 50%. One of my jobs at Blue Cross is I work with large national accounts on strategy and innovation on how to take care of healthcare. And I think I surprised our marketing team because the first week I was there, I made a statement. I said, you know, I'm just not smart enough to design an insurance product to take care of a population that's 50% obese. Now, I guess we could pre-cert McDonald's, or we could come through with some, creative measures. But Jesus is exactly right. We have to work on public health. Public health is a crucial concern for the state. We have to instill in our students in school to develop healthy attitudes and develop healthy health and wellness. And I think the second issue they brought up is very, very valid. You know, we are in the middle of moving from a fee-for-service system to a pay-for-value system. We can talk about price and cost, but at the end of the day, we have to make sure that what we pay for, we get good value for. And if you talk again to the customers that purchase insurance products in the state, that's what they're going to say. They're actually kind of okay with the cost, but they want to make sure that they're getting the return and value for what they're paying for. And I think as we move through that system, Jesus and I were talking before, it's stressful. My analogy that I use a lot is like flying an airplane. What's the most stressful time of flying an airplane? It's the transition. It's the takeoff and the landing. And right now we're taking off toward a value-based healthcare system, and that creates stress. That's why we're having this discussion today. But I think we're all in the right trajectory, which is to move to that value-based system.
I'll expand upon which I think will help drive costs, not necessarily down, but maybe be able to flatten them out. And I think it's the same things that drove our healthcare cost increases significantly certain periods of time, and that's technology. Technology's been a big player in driving cost up. MRIs, CAT scans, every hospital had to have one of each or two of each, you know, and so you didn't have efficiencies within a market. And I'm not going to get into health planning in a different tone, but technology drove the cost in the past. Technology will drive our cost savings in the future, and I'm going to give a couple examples. We have electronic medical records. That just is the beginning of it. Right now you have technology. Every one of us that goes see a doctor, what do you just do before you see the doctor the week before? You go get lab work. Well, there's no reason why there's technology available to help take that lab work and use that lab work to have predictability markers of where you need to be doing what type of treatment. Do you have markers for diabetes? And then you take it one step. If you do your DNA, you do a DNA swab, the combination of medical blood workup and DNA will produce a significant number of medical markers, allow the physician, before you even go be treated, they'll be able to see a lot more of you, of what they see your conditions are, what you're going, and establish these benchmarks that you should then have your health plan or your health strategy based on. And there's no reason why it can't already be done electronically in the future. When you walk in, there's pretty well saying, I have markers for diabetes. The doctor looks at that, puts me on a wellness program associated with how to treat the diabetes. My co-insurance or my medical care should be adjusted based upon whether I comply with that or not. I get to the individual responsibility that way. When I talk about GoPays or co-insurance, I don't talk about financial ones. That's only one piece of it. I talk about healthy behavior ones. Have healthy behavior. It's the simplest one to use, which I don't like to use because I don't smoke. But if you smoke, you should be paying more for your premiums. You should be paying more for every visit you make to the doctor. Well, the same thing, if you have markers for diabetes and your doctor spent the time and energy to start working with you on your diabetes and you don't comply, zap you with individual premium hires or copays hires. That's, I think, the technology of the future. And quite honestly, we don't even know what's out there next. I guarantee you, your BlackBerry can be able to use to read your vital signs if it doesn't already. I mean, things are just jumping, making leaps, so the technology's there. And then just in general, all of the health analytics and biometrics one can gain can be very clearly used more so. And the last thing is, as an example, is the 1115 waiver that we got a year and a half ago, the transformation waiver for Medicaid, has forced for the first time in the recent history of the state, competitive individuals sitting around a table and talking about what is best for this region or healthcare leadership. Where do we have shortage? Where do we have mental health? Or how can we take the county's mental health dollar here and match it and leverage and expand mental health? That is the biggest thing. Getting back to proper health planning. I'm a believer that when the state, I guess it was 85 or something that Dave, I don't remember, when the state sunsetted the health planning commission, a health planning act of this state. We haven't had a health planning statute since then. And we're talking about planning health.
Yeah. No, that's right. Well, there's the SHIC, but it doesn't do the...
Yeah, I understand.
It doesn't do the hardcore.
It doesn't do what I talked about, making the hard decisions in your health plan.
Right.
David, there's one other, to build on what Tom is saying, the fact is that And I think Medicare is trying to do this through the Affordable Care Act to make some changes for innovation and flexibility. But the fact is that you're not going to be able to make meaningful changes if Medicare and Medicaid aren't allowed to be flexible in terms of the way they implement and run those programs. Because if you don't, by allowing public partnerships, et cetera, if you treat it as simply a regulatory system and a medical loss ratio issue, or whatever it is you're measuring success, you're going to really be reaping the same thing that we've had over and over and over again. And we've got to get those changes made in those programs so that we can really have some meaningful reform in this country.
Why not change the medical loss ratio to a healthy ratio? That if you have a score and you got more people healthy, I mean, everybody, the HMOs worry about their medical loss ratio. Shift this whole thing away from MLR to a positive measurement. We got a negative measurement in all of our systems and not a positive measurement. Positive health outcomes.
I think some of the struggle is that a lot of these things are societal issues that wind up in poor health later in life. Patients in the doctor's office, we have to take care of those patients. We're ethically and morally obligated to do that. We need to get back to realizing that healthy living begins when you're young. We need PE in schools. I don't see why there's any reason we couldn't have people who have Medicaid need to prove they go to an exercise class 2 or 3 times a week to continue to get their benefit. Because the things that keep you healthy aren't things you're going to get in a doctor's office. They're going to be good nutrition, weight control, and the healthy habits you take 20 to 30 years to develop.
At the same time, smoking has gone way down in this country. And projections of obesity, I don't know that you can keep, go straight up in a line. There's a certain amount of reversion to the mean. I mean, I think I'm one of the few overweight people in the whole room, as far as I can tell. So, of course, I feel a little uncomfortable about some of it. These draconian initiatives here. But at the same time, are there some things in the way we organize today? In other words, there seems to be movement towards physicians working for hospitals kind of indirectly through 501As and things like that. Is this increased integration of the healthcare system between hospitals and doctors, is that going to reduce costs or is that going to increase costs?
Well, I have kind of a unique perspective. My specialty went through a lot of cost cutting in the 90s.
Right.
And at that point, we had practice consolidators emerge in the marketplace that nationally went up and bought ophthalmology practices to integrate them for shared savings, for communal buying and that. All those practice integrators went bankrupt because once the savings were gone, their model didn't work anymore. The physicians who had sold their practices for stock were left without a practice and had to buy it back from the bankruptcy judge. So I like to see costs happen, but I want to make sure we do it in a way that 10 to 15 to 20 years from now, we aren't all left with physicians who can't practice because the model doesn't work. The shared savings are only going to go so far. There's still going to have to be costs in the system that have to be paid. My concern as a physician, my obligation is primarily to the patient. And this creeping corporatization of medical practice makes physicians responsible to 2 masters. I'm not saying that there isn't some benefit to it, but I also have grave concerns of, are you going to be able to really cut costs when there's a corporate model to drive profits in medical care by physicians' practices? Like Dan said, we're taking off into a great unknown, and that unknown could turn out to be very good, but it also could be that you become a line item and you need to generate revenue for the corporation, and that's through healthcare costs. So I don't really have a clear idea of where we're going to wind up.
Yeah, I think some of those points I think are valid. I think really the issue here ought to be is how can we, as healthcare providers, place people at the center of the system as opposed to being provider-centric, whether it's a hospital, whether it's a nurse, or a doctor at the center of the system. Because I do think that when you have an issue of an illness, what happens right now in the fragmentation of healthcare is that delivery is not seamless. It's in fits and starts. And that causes inefficiencies, and for those families, it causes all kinds of consternation. I can only talk about my own personal experience with my father when he was very ill and had cancer. It was left to us to figure out how to navigate between the various specialists for my father so that he could get well or get the care that he needed. There was no one place where you could go to make sure that that care was integrated. So I think the integration of care isn't necessarily for corporations' benefits or for doctors' benefits or for nurses' benefits. It's to create a system of care for individuals so that we get the best results and the best outcomes for those people. And I do think that in terms of on the hospital side, when you have consolidation, and there's going to be consolidation because of the Affordable Care Act, because people see that there is reduced reimbursements, there is reduced utilization, and a whole host of other things. And that is done theoretically to cut out, basically to improve efficiencies, take out unnecessary cost. But that, I agree with Michelle, that you can only take that equation so far. It runs out of steam, just like it running out of steam when you integrate care. In the end, though, I do think that we ought to, if you look at the total benchmarks in terms of what we as a nation pay for health care, I think there's ways to do the work that needs to get done and stay within budgets or stay within a percentage of GDP that is appropriate. The fact is, we shouldn't be having a medical arms race where, as Tom said, where we have a CT in every chicken pot or in every pot. That creates an enormous cost to the system. And finally, what the Affordable Care Act tries to address, having people uninsured, people who do not have access to primary care so that they can get those preventative services early on in a disease stage, but they get it late in the disease stage, costs the system an incredible sum of money. You've got to get people coverage with insurance so that they can, and you have to have you have to pay enough so primary care providers can be paid to see those patients. But if you have a reimbursement system that is inadequate, those primary care providers won't be able to take those patients. So those are those things that we need to begin to address in a healthcare system so that it's a more rational system than it is now.
Well, I agree with you that we don't need an arms race, but we are in the middle of a healthcare industrial revolution. And it's exciting. And to me, I live in a world where I've never really found that one policy or one idea fits everybody. It's not going to fit every community in Texas. It's not going to fit urban Dallas. It's not going to fit West Texas. It's going to be different. And to me, a robust marketplace that includes all provisions of healthcare, physicians, and hospitals is the way you drive innovation and change. You know, I applaud the work that the hospitals are doing around accountable care organizations. They're coming together to develop value. It's happening here at Seton, and it's a great thing. Why is that so important? Because hospitals can accomplish things, for instance, central line infections. You know, we can debate the cost for putting in a central line all day, and we can get down to some beat to the mean. But if a patient gets a central line infection in a hospital, it costs $250,000. So preventing that central line infection saves a huge amount of cost, not anything to do with the unit cost. But at the same time, a patient-centered medical home here in Austin, and Michelle put on a symposium about a month ago where we talked about that. That's where local physicians come around their own population of patients and manage things like cardiac disease and diabetes and asthma. When they get sick at home, they pick up the phone and call their primary care physician. There's somebody there to help them navigate those choices. To me, a marketplace that has competitiveness and ingenuity within that marketplace is what drives down costs, it's what drives innovation, it's what drives better quality. So to me, I'm not a one-size-fits-all model. I think we need to empower all of these business models and encourage our providers to step up and develop change.
Let me
finish the line.
Go ahead.
If integration is a goal towards reducing duplication, then I'm all for it. But the bottom line is going to, I think, stretch our supply and demand system here. If we don't have enough primary care physicians, I don't care whether you integrate, consolidate, whatever, you're not going to be able to meet what's coming in the door. And I had to watch, I'm saying at the university, I'd just soon you not fund law schools for the next 10 years and put all that money, put all that money in medical schools and get primary doctors out there. I don't need any more lawyers, I need doctors. And it gets real scary when you start looking. I went the other day to my insurance agent and started kind of relooking at all my insurance numbers to see if I had enough money. And now that I got 4 grandkids, and I was blown away over the actuarial table for my 4-year-old grandson was that he was going to live to be 115 to 120. We're not prepared for that type of system in our healthcare system for people to live to be 110, 112. We better be thinking about what do we need out there? Do we need lawyers? Do we need accountants? Do we need doctors? What type of specialists? And not just let it run random because University of Texas wants to build a new building and have more lawyers graduate. That's not the way the system's happening. Sorry, I say that about it, even when we weren't here.
One thing I'll follow up on too is, just so you know, the hospitals don't need a bad rap about consolidation, because the hospitals are doing some good things around accountable care organizations. And why is that happening? Well, it's happening because the hospitals are providing 4 things. They've got an aggregation model, so there's a way that those physician providers can come together. They're providing some local medical leadership because they have a medical director that can inspire and direct care. They've got coordination and technology services, and they've got capital to help put that together. Now, you think, why is that not happening in the physician community? Because it's hard. I mean, physicians are working 70 hours a week. They don't really have the opportunity in the aggregation models. There's federal laws that limit the way they do gain sharing, makes it more challenging to aggregate in that model. I applaud the work of the Texas Medical Association. They're working on a task force grant here to work toward and figuring out a way to build these aggregation models in communities to allow physicians to do the same sort of thing that hospitals are doing. And to me, that creates a powerful marketplace.
You made a very good point that I'd like to expand upon. We tend to say hospital, and I don't know if any hospital anymore is a hospital. It is really a healthcare system. Most hospitals that are going to survive now in the market is a hospital's the core. They have clinics all around that serve that core. They have outpatient services scattered out in the community. That is a healthcare system. So I even have to watch my own terminology and not refer to hospitals, because very few hospitals exist out there. They're really a healthcare system.
I was going to ask, from the point of view of Blue Cross, in terms of reimbursement, how are you trying to drive this value-based as opposed to just fee-for-service? But then on the fee-for-service side, several cases have come to my attention when somebody did a stress test in a cardiologist's office, say 5 years ago, and paid $500. Now they're doing it in essentially the same cardiologist's office, but it's somehow the outpatient department, and the cardiologist is getting about $600, and the hospital's getting about $3,000 from Blue Cross. And is that kind of part of the reason we're seeing a lot of, in other words, is Blue Cross kind of tied into some models of reimbursement that are kind of creating?
Traditionally, we have been in a fee-for-service business, where you contract for performing a service, and whether it's a provider or a hospital. Provider contracts, to be brutally honest, are pretty simple. They're all tied to, CPT schedule. There's not a whole lot to it. But a hospital contract, as Jesus can tell you, very complicated, because there's a lot of imaging, surgery. The contracts are very complicated, which makes that when you start to look at individual fees and how they're dispersed to the final charge document, it makes it look fuzzy. But the take-home message is we have to move to a value-based model. And we have been very aggressive in the marketplace. We just have formed an alliance with THR in Dallas. We're in the middle of an intense work effort with them to help to put together an accountable care organization. Our company, which is Healthcare Service Corporation, operates the most successful ACO in the country, and that's in Chicago. I'd like to think that you could go purchase an off-the-shelf product and just plop it down on THR, but that's not how it works. We meet every Thursday, except for today I'm here, all day long, okay, working with THR and their physicians and their administrators and people with us in our company to develop a novel payment system around value. Looking at metrics, looking at cost, how we take that to market, how we can find a customer that will be willing to pay for it. And the customers are somewhat skeptical that you can pull it off, right? So we have to be able to develop meaningful data to be able to take that to market. So the direction we're going is clearly in that value-based model. I won't talk about it, but I'll tell you the similar products happen in the patient-centered medical homes. And just in the last 6 months, we've opened 26 new patient-centered medical homes. All of those, again, are value-based payment mechanisms where the physicians who improve metrics within their patients get paid more.
David, what I'd say, I mean, I think you brought up the issue in terms of that the testing. And I think what happens is in a system in which you have little or no regulation in terms of where facilities get built and what designation they get, there was a piece of legislation adopted in '09 which allowed the establishment of freestanding EDs that were within some distance of a hospital and therefore could charge hospital-based rates. Essentially, those facilities are urgent care centers on steroids. Right. But if someone who is really complicated arrives at those centers, they get shipped to the tertiary center to be cared for, yet the charges are as if you're a department of the hospital. And so I do think there are some things, that is why I think when you look through the payment system and what needs changes, you need to be thoughtful about how all of that is interwoven and how you go about making some meaningful changes that does not provide disincentive to providers, doctors, to see patients and to be able to do the right thing, provide the right kind of care, and that is going to take some thought because it is a value-based system. I mean, not a value-based, but it's a volume-based system, and you've got to begin to make that shift. It's why the ship is taken off, and we've got to figure out how to do that without doing harm, to use a doctor's creed.
The cardiology example that you gave is a response to a change in reimbursement policy where money is driving the system. Doctors are paid on a whole different method of payment than hospitals and the rest of the players in the healthcare world. And cardiologists used to do things in their office because they got paid a fee that covered their costs under our sustainable growth rate, the SGR. Well, that got cut severely to the point where it didn't cover physicians' costs to take care of patients. It moved to the outpatient world. Unfortunately, it's a very, very expensive place to do it. That's why you've seen basically all the cardiology practices in Austin are no longer individual. They've been bought by a system because they could no longer sustain their practice with these fee cuts. I've looked at this for many years, and I've been in practice for over, close to 30 years now. I've been there before PPOs and HMOs when patients had to come in and pay their bill to the doctor directly. That limited costs. You aren't going to look somebody in the eye and charge them $100 for something, but when you charge an insurance company, there's this blind third party. I personally, and this is not any organization I belong to, but my personal opinion is we need something like the Federal Reserve looking at healthcare in our country, what's best for the culture of our country. And it can be regionalized just like the Fed takes care of little community banks as well as Citibank and other Bank of America type things. But no one's looking at the big picture of how many CAT scans there are. Do we need to have another MRI? Is this really effective? We need some non-political, non-lobbyable association that will look at that. I know. Right now, that's not going to happen because healthcare is really fragmented into lots of little lobby groups who go to a politician and lobby their best thing for their slice of the pie. And it's very hard for a politician not to do something that will gain votes for them. That's what they're there for, ultimately. Until we neutralize that effect, I don't know if we'll ever really get this under control.
I think that's an excellent point, very excellent point. If you kind of look at I think the other fear there, and probably it's a very similar fear as the marketplace starts moving with all these things trying to be efficient, what's really going to happen, the bureaucracy will not come along that fast. When you think about Medicaid and Medicare established in 1965, there was only one major reimbursement change in all that period of time, and that was when DRGs came in. And DRGs, excellent concept, but it was never intended to be, that's it. It's something you build on, something you modify. I think now you're just starting to get some modifications to it. And the bureaucracy tends to drag things at a slower pace. But building on you, I've always believed that our healthcare system, I got to watch, I made me lose my Republican stripes, but I'll say anyway, healthcare is a public utility. What you need to try to do is create a competitive market within that utility and balance that thing out.
Well, the only
I don't mean government to run it. I mean, it's just got to have the framework. Somebody's placing some controls of practicality in there.
The only comment I would make is that it's not easy, okay? It's not in cost containment. I saw that question mark on our title today. Is cost containment possible? I guess the question is, cost containment is not easy. Okay, 7 years ago, I was down here doing a panel discussion. I think I was with this guy right here, and I stepped out and I had a phone call from my 85-year-old father. And he never calls my cell phone. He had an aortic aneurysm. We had decided not to treat it. We made a utilization decision not to treat it. He's 85 years old. I answered the call, and he says, I got pain in my legs, numbness, tingling. They live in the middle of the hill country. And I said, well, jump in the car with my 80-year-old mom, how safe is that, and drive to Providence Hospital. And I drove up from Austin and met them. And I walked in, 2 large bore IVs and suppressors and everything, but he's alive in the ER, 85 years old. And the doctor comes in and says, I got to do this Dacron graft and all these changes. And my mom, to your point, looks across and says, well, that sounds awfully expensive, And of course, that's the mother of an insurance executive, right? And so I said, well, he's got to do the surgery, right? So he made it to the ER, so we do the surgery. Okay, he's 93 years old, lives at home, drinks black coffee every day. These decisions are not easy. Federal Reserve or not.
Yeah.
So I guess the last question before we open it up, we still have a little more. Uwe Reinhardt had an editorial, had an op-ed in the I think it was in the Times about 3 weeks ago, arguing that it wasn't so much a cost problem as a price problem. And basically arguing that there was just a lot of, and partly, I think, because of Governor Rick Scott, who essentially caused, when he took over Columbia HCA, began to acquire hospitals, which then led to the hospital markets to contract. It certainly happened here in Austin, where Seton and Brackenridge got together, and then the HCA got together with a couple other hospitals. So in a number of markets, it's thought that there isn't enough price competition, and that for somebody like Blue Cross, they have to include everybody in their network. Do any of you see that as a problem, or and if so, what solutions might there be?
Well, as long as Seton's in the network, we don't have a problem. I do think that there were, prior to that consolidation, hospitals that were standalone. Brackenridge was no one. I used to manage, didn't used to manage it, but it reported into the city structure. It was a price taker. What does a price taker mean? It meant you were the trauma center for the region, but you were at the mercy of the payers. They said, this is all we're going to pay you for that service. And what was the result for Brackenridge Hospital? It was into the general fund for $30 million. $30 million is what the public owed. I mean, basically was funding or underwriting that public safety net. That's the reality. So there was that now consolidation, and that created economic power. So when you negotiated contracts, you got what you thought was fair reimbursement for the work that you did. And hospitals generally are a low-margin business. There are not a lot of high margins made in hospitals because they are very capital-intensive, enormous amount of cost that's sitting there at the ready in case you have some traumatic event where you you come up quickly and you're able to deal with those concerns of the community on a very, very rapid basis. A lot of call coverage, et cetera, that you need to get done. Those are just the realities of that kind of an institution. And I realize that that's expensive, but it's analogous to, if those of you that are citizens of the city of Austin, you have at the ready for you right now numerous fire departments. Numerous fire departments. I would say maybe a handful of them operate with any degree of frequency. Most of those expenses are embedded. They sit there at the ready. In case you have a major catastrophe, then those firefighters are up and running and they take care of that fire. But it costs a lot of money to do that. It's very, very similar.
But one of the hidden issues you brought up a little bit, I think, is an issue that doesn't get hit in the debate because you get accused of all different things for it, is the issue. I'm going to use my mother-in-law and my mother's example. My mother's 92 years old. My mother-in-law is 91. My mother-in-law goes to the doctor. They want to do some procedures on her. She goes, hell no, I'm too old. I don't need any of that. My 92-year-old, we'd like to do these comprehensive tests on you. I go, Mom, what do you need them for? Well, I want to see what's wrong with me. I said, we know what's wrong with you. She said, but Medicare is going to pay for it, so don't worry about it. That's what's wrong with the system.
And I think The problems we have with pricing, specifically that article you referenced where the uninsured pay the highest prices, came from the culture of cost shifting that occurred decades ago in medicine, where Medicare and Medicaid didn't pay the full cost of that. The costs were shifted to private health insurance. Unfortunately, the uninsured are the only people left that come in and get those costs, because that's the only place left to shift the costs to run something anymore.
And I sound like a broken record, but it's not a price, it's not a cost issue, it's a value issue. You know, if you're paying for a service and you're getting good value for it, and it's making a difference in the long-term care of a patient that's positive, then it's probably worth the cost.
Just one. My mother lived quite a while too, and Warren Buffett was asked about his health, and he said, well, he'd researched it, and he found that your life expectancy was closely related to your mother's life expectancy, so he went out and bought her a treadmill. So I guess the one other question I had for Dan was the medical loss ratio. In other words, as part of the ACA, large groups have to spend at least 85% of the premium dollar on medical expenses, and small groups 80%. And some people have argued that that really cuts into the incentive for insurance companies to spend much money on value, in a sense, in terms from the point of view of controlling costs of providers or worrying about costs, because if they're going to bring, because their costs, of course, are also all of their administrative marketing and kind of healthy incentive stuff, that's coming out of their 15%. So they don't want to spend more on that. They just as well let it be spent on expenditures. So do you think this, in a funny way, this MLR thing is going to reduce cost initiatives by insurance companies?
Well, just for the room, because we start talking, it's sort of the parlay of the insurance industry to speak in as many acronyms as possible, because that way nobody really knows what you're talking about. But what is MLR, medical loss ratio? Well, that's really going to be a ratio between the benefits that are paid on behalf of an individual compared to the premium. And so it becomes a great soundbite when you want to go lobby for that issue to say we want to cap or create an MLR. But what you actually do is you put an equation, if you will, in the law. And as you've been around a long time, anytime you put around equations in public policy, you create kind of weird incentives and disincentives. And let me give you an example. So one of the things is on the 85%. So 15% of those costs have to be attributed to administration and no more than that. And 85% has to be paid in premium. But let me give you an example. In small group and individual, which is 80%, 80-20, not 15 and 85, those are the most expensive insurance policies to sell. And who are those getting sold to? They're getting sold to individuals and small groups in Kermit, Wink, Odessa, Harlingen, Edinburgh, parts of Texas that require independent agents to go out and speak to those small businesses and small individuals to sell that insurance product. And guess what? Their premium for doing so is part of that MLR. Those are the same agents that will also be working with those individuals and small groups to enroll them in wellness programs that are paid for a part of their benefit, or health programs that are paid for a part of their benefit. Help them navigate through the healthcare process to make sure that they make better choices. So in one example, I think you could say that the MLR has created kind of interesting incentives and disincentives. We're a Blue Cross Blue Shield, you asked specifically about us. I mean, we're a non-investor owned mutual company on behalf of our customers. I like to say that, we make a profit to perform a service, whereas if you're for profit, you do a service to get a profit. So we're a little bit weird. So we've always been able to function in that environment, and we kind of had a direction to function in an environment where we try to return service to our members. So for us, it wasn't a huge impact to our business because we operate that way. But again, as far as the incentives and disincentives, I think anytime you introduce a ratio into the law, people are going to find a way to use it.
What scares me about that artificial ratio, because the doctor's exactly right, and when I oversaw and set Medicaid managed care rates here for the last 9 years, and we did never have a hard established medical loss ratio. There was kind of implied benchmark you look at, and the reason why you didn't want to, you want to have a relationship with that health plan out there. There's going to be outliers, and there's going to be things you want them to drive the cost down, not feel like the goal is to meet that 85% threshold or that 80% threshold. So we preferred to have a kind of a relationship where they knew we had a kind of a cap of what we thought their administrative expenses should be, and let the medical expenditures go where it goes based upon good management. And we thought some outliers in there, we'd sit down and say, why are you at 86%? Or why are you now all of a sudden at 90 and you're losing money? Let's talk about how do we tweak what we're doing in the Medicaid program. That's the way a system we're setting it at 85% artificial out there. It's just going to be that. It's going to be an artificial 85%. Nobody's managing, and they're set back saying, well, if you're at it, okay, everything's okay in the plan, right, which may not be true.
Right. And what I'd add to that, David, is I think that what sometimes we lose sight of is we try to manage the health of individuals in a plan through a benefit design. And that's effective only to a certain point. And that benefit design is intended to hit these ratios that you talked about. What we're finding in the extensivist clinics that we've created, which we don't get reimbursed for because it's not seen as an expenditure that's reimbursable by Medicaid for those Medicaid patients. In the extensivist clinic for the special needs children's, we're driving down ED rates, we're driving ED utilization rates, inpatient admission rates, and what happens is that we've brought specialists together, we brought in navigators, we brought in social workers to work across a spectrum of issues that need to be to support those families to keep people well. We've done it in the chronic illness clinic at the University Medical Center Brackenridge. It's the same kind of issue. People with congestive heart failure, chronic obstructive pulmonary disease, et cetera, to manage those patients in a very different way. Now, we're completely at risk for the uninsured at UMCB, so that it's any admission we take out, we save money on. But again, I think insurance plans, Medicaid, Medicare, it is about how you actively manage patients in a very different way than in a passive way, which is you do a benefit design and then it's a mother may I do this, mother may I do that, and if it's a no, you don't get paid for it. And I think we're going to have to evolve to a different kind of approach with respect to insurance coverage.
So I think we're ready to take questions. Over here. And could you address the question to one or two of the panelists possibly?
I'm going to break the rule before I start. My name's Amy Hagstrom-Miller. I run a group of women's healthcare clinics called Whole Women's Health. And so this conversation is fascinating to me on a couple different levels. One, as a reproductive healthcare provider with 5 different sites in the state of Texas. 2, as a small business employer who provides health insurance coverage to over 100 people, primarily women. And it's one of our biggest expenses, right? And so I think it's interesting. I could ask you millions of questions, but I think it's very interesting when you talk about cost containment, and a lot of the examples you gave were punitive, rather punitive. You know, like how can we curb obesity, how can we curb diabetes? There were punishment sort of based. And I'm wondering if, I'm a big fan of Chip and Dan Heath's book, Switch. And I'm wondering if any of you have done any thinking about bright spots thinking and studying sort of what's working in the healthcare system to positively motivate people toward positive change instead of a punitive approach. And if you could talk a little bit about that.
Well, I think when I grew up, there was the President Kennedy Medal of Fitness. We need something like that back in the school systems, but also include good health policy, good health activities, you know, healthy eating, exercise, not smoking, because if you don't start young, you're going to have chronic disease when you're 40, 50, 60 years old. And the rates of that is going up alarmingly, like Dan said, the obesity rate. Part of that's our change from, you know, an industrial age to an information age where people sit. Well, we're not going to change that culture when they walk into the doctor's office with a problem. You have to start young, and we have to get our education system to think about not just intellectual education, but cultural education to live a life of wellness and health.
And I think Tom did raise, I mean, I think he talked about in terms of that incentives is to incent good behavior. And so I think I mean, I think you ought to do both. I mean, I do think you do need to incent good behavior and have people pay less for good behavior or whatever it might be that how the incentive looks. But I'd also say that you can't get, as Michelle's saying, fundamentally, My children are now much older. I didn't realize PE had been taken out of schools. I cannot believe that we've done that. I cannot believe that we haven't addressed the food deserts that exist in our communities where people can't get good nutrition. That the first thing when they walk into the grocery store is the high starch and high fat diet, because that's the cheapest. That's where their dollar can get spent instead of spending money on quality foods that can have good health benefits. I think all of those social issues need to get addressed in a very different, systematic way. You know, I made a comment the other day when I was at the city. I never realized when we created subdivisions that allowed swimming pools to be privatized, where homeowners' fees paid for those swimming pools. What ended up happening is that you created the commons. Instead of having a common platform where everyone used, now you created these private systems. And so the people who could afford those enclaves had that available to them, where the people that couldn't afford those enclaves didn't have that available to them. Same thing with PE. I think the reason PE got taken out of the schools is we have soccer clubs, we've got baseball clubs, we've got football clubs, and the families that could afford those things, their kids continue to participate in those events. And the kids that couldn't, because their parents worked two jobs and weren't able to do that, they sat at home and watched TV and played video games, and it created an issue for us. We've got to address this as a community in order to make a difference. And
to answer your question, that's what I think about every day. I get up every morning, and that's what I concentrate on, is how to put together plan design. I'll get real practical for you for just a minute, because I think it's what I like to talk about. Let's pick two choices, kind of pretty simple. If you're trying to encourage, I'll say, rather than force, an employee, for instance, to make a choice, okay, then disincentives work very well. Smoking is a great example, okay? So charging a smoker more within an insurance product tends to be a pretty good disincentive to drive them to behavior, okay? And you might say, well, what's the charge? Well, it depends on what the company is willing to do, but I'll give you an idea about the cost. A smoker within your health plan, we just met with a customer yesterday, is a $5,000 per year higher cost for that smoker compared to a non-smoker. Huge cost difference, right? As far as lifestyle changes and behavior, incentives work really well, okay? The challenge there is tying an incentive to a meaningful value. Meaningful value. It's just, it's difficult. You say, well, $50 if you record your weight on a website, we'll give you $50 a year. I mean, does that have a powerful enough effect on that member to be able to make them get up every morning and say, I'm going to exercise so I get my $50 at the end of the year, okay? So the idea is how you tie those incentives to meaningful change. And then Michelle hit on something, and she just slid it under there, but I'm going to tell you it's the biggest challenge, and that's communication. So you can come up with the greatest ideas in the world, but if you can't figure out the channel of communication to be able to get an influence behavior to occur, then it's not going to be effective.
Expand upon the wellness concept is not just putting the incentives and disincentives in the premium, but the fact our technology. So you go to the doctor if you had your lab work, he sits down with you and they're going over all your signs. Well, technology's there for that lab to have it on the cloud in your name, that you can look it up and track it each 6 months. You go to the doctor, so you're participating in knowing what those things mean on an ongoing basis. That technology is here today. We just not have integrated into our medical record technology and bring these things in together, so you as a consumer have more information to help you make the right decisions when you're in the store. So I think I think about a lot about the wellness side of the program, and it's just not exercise. It's bringing all these things. And the fact is, our technology in these areas is going to leap the next 4 to 5 years, that we should know a lot more what makes us healthier and prevent certain diseases.
We've got one back here.
Well, I share the concern that was expressed about the sort of agreement that seems to be developing across the political spectrum for rather punitive measures against individuals. And I think it's one step from saying, as Tom Sees did, that maybe premiums should be different, to Dr. Berger suggesting that maybe a Medicaid patient who doesn't do her exercise shouldn't get Medicaid. And I think it's all very dangerous. And it's also very intrusive. And we brought down smoking rates without doing stuff like this. Because if your doctor is monitoring you and stuff, what is this going to do for your doctor-patient relationship? And also, what does it do to be so monitored and punished all the time? It doesn't seem like the kind of society I want.
Well, I'm sorry if you thought that I meant they should not get Medicaid. I want them to be incented. They get a better benefit if they do the exercise program, if they do the things that's going to take a Medicaid child and make a healthy adult. because we all pay those costs, and it's going to be much worse if we don't incent people to get healthy. You know, right now in Texas, 60% of the births are Medicaid births. If those 60% of kids could be made healthier, long-term we're going to save costs for everyone in this room. I just want more incentives to get good behavior there. Right now our society doesn't seem to reward good behavior in the way that gets results down the road, was what I meant.
And I do think, you mentioned the issue of smoking. I mean, I think for reasons that I can't completely explain, people have lost a little confidence in government. But in the 60s, when smoking was really a problem, the Surgeon General warning went on the cigarette, on the pack. In addition, good governments began to raise the taxes for cigarettes. So those became expensive. If you wanted to have that habit, you were going to have to pay more money to do it. I can think of the seatbelt law. When I grew up, we didn't have seatbelts initially in the 50s. In the 60s, we adopted seatbelts. Again, government regulation was stepped in and said this is something that needs to happen. I think that rather than saying it ought to be just one way, there's a lot of different ways to do smart policy that can have good outcomes without it seeming to be punitive. But what you're doing is allowing the tax structure to incent the kind of behavior you want in your communities that can benefit all of us as a community.
The only comment I'd make is that, you know, governments tend to act when there's crisis upon them. And unfortunately, you know, obesity is becoming a crisis. You heard the discussion earlier about sugary sweetened drinks. Who in the room knows where Dublin, Texas is, right? Okay, so I grew up on a cattle ranch outside Dublin, Texas. And I will tell you, coming in from working and having a Dr. Pepper with a bag of peanuts after hauling hay all day was a great thing. It was. Sugary drink, okay? But my son, who drinks a 64-ounce big gulp while playing video games, that's the problem. You know, we've got to make, you know, I poured that much sugar into a cereal bowl because I thought I could make an impact statement. It really didn't work, okay? But the take-home message is we've reached a big gulp society, okay, where the government is feeling the response of having to make those changes. And I think at the end of the day, we have to take care of everybody. That's the kind of society that we live in. We have to take care of people that we serve, and that's what we do. And I think that's what the response that the government's stepping up to change, to try to challenge.
Hi, I'm Stephen Pond at Adult Children's, and I live and breathe childhood obesity and school health for all my life. So I think we're starting to talk about the bigger forces that are at play, and so those are certainly aspects that we need to fight with regards to childhood obesity. You know, manipulative advertising by Coca-Cola and other unhealthy food companies to our kids, and as healthcare professionals, we can advocate for those things and talking about food deserts and physical activities. And I mean, again, I think, you know, we're Austinites, are the hardest working Texans. We work super hard, and we care for our kids' health, yet we face a childhood obesity epidemic here. So there have to be other forces at play beyond just laziness for this to go on, if we're hard workers and we care about child health. But since we're here for healthcare, and I don't mean to single out Blue Cross, because I think y'all do great stuff, but with regards to childhood obesity and healthcare and the conversation through Jesus' support and Adult Children's and some local philanthropy, we can have an obesity center here at Adult Children's. However, obesity is not recognized as a medical condition by any health insurance company nor Medicaid in Texas. So for us to be able to proactively be a good part of that conversation, not the solution, but be part of it, then what are your thoughts on how we can frame that beyond just preventive health care once a year, but have the ability to see kids back before they have diabetes or before they have a stroke or heart failure?
A very complicated public health discussion, no doubt about it. And, you know, one of the things that I like to tell people is that I wish there was a policy sometimes that I could just say, okay, this is the policy that we're going to change, and it's going to affect a difference. Childhood obesity, it's the 1,000 nudges approach, okay? There has to be 1,000 nudges. There's got to be, we've got to work on maybe some provider changes to make sure that the providers have the opportunity to counsel parents and children on the way that obesity should be addressed. You know, we work with local YMCAs to help, you know, local YMCAs help empower their programs to help children as well. Again, it's the 1,000 nudges. It's the idea that we have to raise public awareness around childhood obesity, educate parents, and also work on innovative models to help deliver that as well.
But do you all think that medicalizing social problems is either the efficient or cost-effective way to go? And I mean, would seem to me that initiatives in the schools and the Y and all kinds of things would be a lot less expensive than being reimbursed for seeing people who have the diagnosis of obesity. I mean,
there are specific medical consequences from having that diagnosis, so I would advocate that it is a medical condition. I absolutely believe that social determinants of health are massive forces as well that have to be addressed, but both parts are needed to really have a long-term and quick solution.
But by medicalizing social problems, and we do that with Medicaid and a lot of things, aren't we kind of taking money away from far less expensive but appropriately trained people who could be providing services and reducing the medical costs down the road? I don't know. I mean, yeah. Have we run out of time? Yes. What? One more question?
Yeah, one here.
He's got one right here.
Ready?
Right.
Okay, about a month ago, or a couple months ago, Time Magazine had a special report, devoted a substantial part of their magazine to an article by Stephen Brill on why medical bills are killing us, which is sort of the topic of what we've been discussing here the last hour. And another thing that was mentioned was the ability of people to, when they go into a store, they can choose their products. When you have an accident and you're bleeding and you're loaded into the EMS, you don't have much choice on which hospital you go to. You're usually pretty interested in going to the first one you can get to.
That's your choice.
What I would be interested in seeing, you mentioned that the individual should be more inclined to take care of their own health care as much as possible, preventive in other ways. And in this article, they mentioned that an aspirin in one hospital might cost 50 cents, another hospital might be $7 for the same aspirin. Is there a way that we could make a cost comparison on hospitals to have perhaps a itemized list of certain fundamental things, such as aspirin, so a person could go to the internet and go through sort of a catalog and comparative catalog of the various hospitals in their area and come up with some at least slight index of which one might provide more benefit for the same cost?
Well, you're asking me? Since I was trying to avoid that question. But let me say this. I do think we're moving toward greater transparency. It's not where we are today, and we're not there for a lot of reasons. There are a lot of reasons in terms of how these contracts get negotiated with payers. It's about what the cost structure inside of a specific facility looks like, and pricing then the charge master gets adjusted so that there's a sufficient revenue that gets generated by the work that gets done to be able to pay for the expenses and produce some margin. So what I would suggest is that as that becomes more transparent, you'll see shifting of the $7 aspirin might be shifted to some other different activity that would be less appear less onerous. And but the fact is that the revenues are still going to need to be generated at that facility so that they can capitalize themselves and make a margin. You started the question by an ED visit, a trauma visit. You may not know this, but when you arrive at that trauma center, the hospital has already spent millions of dollars to have doctors ready to be able to manage that specific trauma and put that individual back together again. Not all those costs are recovered in many instances if the person has a different kind of insurance that doesn't pay well. And that cost is embedded inside the cost structure of that hospital, and it's reflected in its pricing. I think part of it is you have a larger issue in terms of how you begin to fix the payment system, how you begin to get more people covered by insurance that actually pays for those things, and then begin to create a system of care where you might be able to squeeze expenses in such a way, take expenses out of hospitals, out of different other services, so that there's not as much cost that needs to be borne on a day in, day out basis by facilities and providers. It's a complicated question. I know that's maybe not a direct answer, but
cost accounting and transparency are two of the most complicated challenges for the healthcare industry, and they both need to be on a fast track. That fast track might be in my 4-year-old's lifetime.
Right. The one problem with Medicare and Medicaid was it brought accountants into the healthcare system big time. And basically, you suddenly got paid for cost allocation in a very significant way. I think we should thank the panel. I think it's been very